Ventilator settings, there's also ventilator settings. One is rate, and that's how many breaths per minute you are going to be setting the ventilator at. Tidal volume, again, we just mentioned they like lower tidal volumes because there's less chance of problems such as a pneumothorax. So they will set that tidal volume based on the patient's ideal body weight. PEEP is positive end expiratory pressure. So this is the pressure at the end of expiration to try to keep those alveoli open. They call that recruitment. So you're recruiting the alveoli. A normal PEEP for you and I is 5. So what happens is the higher the PEEP, the more difficulty we're having oxygenating the patient. Pressure support basically is just extra pressure that the patient gets upon inspiration. This is normally seen with the SIMV mode, or synchronized intermittent mechanical ventilation mode, which is used more for weaning. And the oxygen we mentioned already is the FiO2. So as I said, one of the concerns with FiO2 is if it's greater than 40% for an extended period of time, then the patient's lungs can become damaged, and then there's less oxygen available or less surface area available for gas. So this is a ventilator patient, and this ventilator patient, as you notice, he is on a ventilator, and he has what's called an endotracheal tube that actually goes down into the trachea so that the ventilator can help the patient breathe. The patient also has a nasogastric tube in, but most of the time what you're going to see in the critical care areas is not a nasogastric tube, but you're actually going to see a OJ, or an oral gastric tube. So that's basically what you'll see there in relation to a ventilator. So the two modes of ventilation that I would like you to understand is assist control and SIMV, or synchronized intermittent mechanical ventilation. So basically when we use assist control, this is when the patient is in the acute phase. The patient is really sick, and what assist control does is take the work away from the patient for breathing. So what we get with this is you have to have a set rate, and as you see at the bottom under example, it says AC 14. That's how many breaths per minute the patient is going to be getting on the ventilator. You also need to have a set tidal volume, and as I mentioned earlier, this is usually based on the patient's height and weight. And we try to keep the tidal volumes a little bit lower so that we don't have to worry so much about complications from too much tidal volume. So the tidal volume in the example below is 450. So one of the things that you're going to notice with assist control, and I'll show you in the next slide, is that the patient is allowed to take their own breath when they're on assist control. However, the total volume, or the tidal volume, every time the patient takes their own breath, they get the same tidal volume that they get with a ventilator breath. So if the tidal volume on this slide says 450, when the ventilator kicks in and it gives a breath, the tidal volume is going to be 450. When the patient takes a breath, the tidal volume will also be 450. So with assist control, the tidal volume is consistent even if the patient takes a spontaneous breath. So every breath is supported with assist control, whether it is the machine or a spontaneous breath. So as I mentioned earlier, the reason for this is these patients are really sick, and what we're trying to do is we're trying to rest that pulmonary musculature, or the pulmonary muscles. When we do the work of breathing for the patient, or the ventilator does the work of breathing for the patient, it helps to decrease oxygen consumption and try to optimize cardiac output so that the organs are getting perfused. PEEP, as we mentioned already, is positive end expiratory pressure, and what that's for, as I already said, is to keep those alveoli open. The problem with PEEP is the higher the PEEP, the more difficult time we're having oxygenating the patient. So we have to be very careful because this is adding pressure to the patient upon expiration, and so we can have problems such as baro or volume trauma, which just means increased pressure or increased volume, and that can cause the patient to have pneumothorax. With assist control, there's no pressure support because the patient is always getting positive pressure with the assist control mode. So down at the bottom, you'll see that the PEEP is 5, and that's normal physiological PEEP. And then the FiO2, which is the oxygen, is set at 100%. Now remember, as I mentioned earlier too, one of our concerns with high oxygen levels greater than 40% for more than 24 hours is that it can start to cause some damage within the lung tissue, and we do not need that. So it basically fries the lungs, and therefore we have less surface area for gas exchange. So this is just a picture showing you assist control ventilation, and the control are the ventilator, the assist is the patient. So if you notice, the tidal volume is the same whether it's the control or the ventilator or the assist which is the patient. So they're getting the same tidal volume regardless of whether it's a ventilator breath or a spontaneous patient breath. The next mode is SIMV, or synchronized or spontaneous intermittent mechanical ventilation. And this basically is a very common mode of ventilation that we use today. And so this mode makes the patient have to do some of the work of breathing on their own so that we can keep those muscles strong. Now, sometimes patients are just put on SIMV and not put on assist control. And if they're just put on SIMV, the goal is to allow them to take spontaneous breaths so their muscles don't get weak. So we are starting many times with this mode too. We use this to wean the patient off the ventilator. The big difference with spontaneous intermittent mechanical ventilation is that the machine does not support the spontaneous breaths. So what happens is we do have a set rate again. So at the bottom, you're going to see IMV of 8. So the respiratory rate is usually lower with SIMV because we want the patient to be able to take more breaths on their own to keep the respiratory muscles strong. They have a set tidal volume with each assisted breath, and by that I mean each ventilator breath. So the tidal volume on this patient below is 400. Now, each spontaneous breath is given something called pressure support. So what happens is that what happens with this is that the ventilator breath gets a tidal volume of 400. When the patient takes a spontaneous breath, this is where they'll get that pressure support on inhalation to try to increase that tidal volume. So the tidal volume in this spontaneous in a patient breath may only be, say, 300 or 350. But as the patient's respiratory muscles get stronger, then they're able to get a higher tidal volume. They still get PEEP. The PEEP here is set at 5. And down on the bottom, you'll see a PS, which is actually the pressure support of 10. And then pressure support can range anywhere from 5 to about 25. And then the FiO2 here is at 50%. You need to get the FiO2 somewhere between 30 and 40% and keep the PEEP down the PEEP needs to be around 5 before you can actually start weaning the patient off the ventilator. So this is just showing you a picture of synchronized intermittent mechanical ventilation. If you notice the IMV is a ventilator breath. So on this picture, you'll see 2 ventilator breaths and you'll see 2 patient breaths. If you notice, these are the tidal volumes. So the ventilator breath, they're both the same size, aren't they? But when you look at the patient breaths, what's happening is I want them to get as high as that ventilator breath because that's the set tidal volume, which in this case on the patient that I had was 400. So what that means is the patient's own breath is just getting that pressure support on inhalation to try to increase that tidal volume. So this person can still take spontaneous breath. So let's say the ventilator rate was set at 8 and UC 16. Well, that means that the patient took 8 spontaneous breaths on their own. So this is just showing you that the patient breaths are just supported by pressure support, and we've got to work those muscles and get them stronger so that patient can get that higher tidal volume. Here's just showing you the difference. The top one is assist control. If you notice, assist is the ventilator, and then the control is the patient breath. If you notice, each of those are the same height, the same tidal volume. On the bottom one, the IMV is the ventilator, and of course the smaller one is the patient breath. So this one is where the patient spontaneous breath gets only that pressure support on inhalation, and so the tidal volumes may not be the same. So this is pressure support ventilation, and pressure support ventilation is just that. What this does is this allows positive pressure during inspiration. So what it's trying to do is help this patient get a higher tidal volume. You can also, on pressure support ventilation, you can set an FiO2, and you can also set a PEEP on this patient, but it does help to reduce the work of breathing, and this is also used in the weaning mode. Okay, so positive end expiratory pressure I have talked about a little bit already. It's positive pressure at the end of expiration, and what I've also mentioned is that normal physiological PEEP for you and I is 5. So you can set this PEEP on the ventilator, or respiratory therapy will be setting the PEEP on the ventilator. And basically, as I said, what we try to do is we try to what we call recruit the alveoli. So what it does is try to keep those alveoli open so that we're getting better gas exchange. However, the higher the PEEP, the more difficult it is to keep those airways open. And my concern with a higher PEEP is that the higher the PEEP, the more volume and the more pressure, and that can lead to a pneumothorax, or it can also, it increases that interthoracic pressure, and it's going to decrease that venous return to the heart and compromise cardiac output. And what you'll notice is that that patient's blood pressure is going to drop. So PEEP is added to ventilator breaths, and many times we use PEEP because we can increase the oxygen level with PEEP, because what it does is it makes that alveoli bigger and gets it closer to the circulation in the lung, to that pulmonary capillary membrane. So hopefully the goal is to maintain or improve oxygenation without having to increase that FiO2. Because remember, the higher the FiO2, then we have more concerns with damage to the lung tissue. So if the patient is unable to tolerate lowering the FiO2 also, so let's say the patient's FiO2 is 100%, and if we try to decrease that FiO2, the patient's oxygenation level decreases based mainly on blood gases, but you can also check a pulse ox, then we have to add that PEEP. And the goal, as I said, of adding that PEEP is to try to keep that FiO2 lower and to also better oxygenate the patient. So there are some issues when you're talking about PEEP. So you can also do CPAP on a ventilator, and sometimes what will happen, they will do what's called CPAP trials on patients. And what we're trying to do with a CPAP trial is we want to try to see how well this patient is doing so we can hopefully get them off the ventilator. So many of the patients that are on ventilators do have some form of sedation. So what we try to do is take them off sedation for about an hour or so that the patient is alert and awake. because remember, to be on CPAP, the patient has to be able to breathe spontaneous. So this is also sometimes referred to as a spontaneous breathing trial. So basically, this is usually done in the mornings, and we don't have any set rate or any set tidal volume with PEEP because these are spontaneous breaths. So basically, we just have that continuous positive airway pressure, which is all the time. And then we can also add a little bit of pressure support when they take that breath to try to get that bigger tidal volume. So what you need to do is monitor how the patient is doing when they are on CPAP. So if we monitor their respiratory rate, we look at what kind of tidal volume, and we're looking at their O2 saturation. What you're going to find is that many patients may not be ready for this yet. So you may start looking at the patient and see that they're struggling to breathe and their oxygen levels aren't doing very well. So that's why we do what we call this CPAP trial, because it's one way to determine whether or not this patient is ready to come off a ventilator. If they're not, the respiratory therapist can do multiple things. One of the things they can do is say, okay, I'm going to keep them on CPAP, but I'm going to give them maybe 4 ventilator breaths a minute, or maybe 2 ventilator breaths a minute. However, if the patient is really fatiguing and they're awake and alert, they're going to get anxious. And so many times they have to just put them right back on the ventilator. So the example is the CPAP pressure is set at 5, pressure support is 15, and then the FiO2 is set at 40%. So assessment of the ventilator patient, regardless of what the ventilator is saying, you always want to assess your patient first. So when they put this endotracheal tube in, what happens is there's a cuff on it, and then they inflate that cuff. And so proper cuff inflation is necessary to prevent tracheal irritation and damage caused by that balloon that's blown up in there. And patients are usually only intubated for about 2 weeks. And if they're still on the ventilator after about 2 weeks, what happens is they have to go have a trach put in. Also, what happens is when the trach is put in, they extubate them. So the endotracheal tube is taken out. So is the oral gastric tube that is put in. So they usually have to put a PEG tube in at that time also. So a couple of the things that you need to do to help manage breathing in these patients is keep the head of the bed elevated 30 to 45 degrees, because that helps to facilitate breathing. The other thing that it does is it keeps those secretions in that stomach, so we don't have to worry about the patient aspirating. You want to suction only as needed. Don't suction the patient just to suction the patient, because you only need to suction them when they have a lot of secretions. So many times before you suction, you want to make sure that you hyperoxygenate the patient. There is a button on the ventilator that you can push that says hyperoxygenate, and then you want to suction your patient. Now, when you're suctioning your patient with the Ballard suction, one of the things that you have to make sure of is when you start pushing that suction catheter in, the minute that patient starts to cough, pull it out, because coughing is good. So you've stimulated coughing in that patient, and that helps to mobilize those secretions. So then you want to pull that catheter out, but make sure you pull it out all the way. And so that's one of the things that you need to do. And you want to try to suction for the shortest duration possible, because when you suction, not only are you taking out secretions, but you're also removing oxygen. So that's why I tell you, once that patient starts coughing, you want to stop. If the patient doesn't cough, then you want to put it in all the way and then pull it back. We used to instill a little bit of normal saline into a port off the endotracheal tube. They used to be in these little pink things, and they called them pinkies. We don't do that anymore, because we're putting that fluid in there. And then our concern with that fluid is if that fluid sits in there, then we have to worry about infection. You always want to turn in position patients, because turning in position helps to mobilize those secretions. Hydration, also make sure the patient is getting adequate hydration. So we know that fluids help to liquefy the secretions, making them easier for us to remove, or if the patient does cough, making them easy to expectorate. The patient on a ventilator can be given medications. They can be given bronchodilators. Respiratory therapy can do this, and those bronchodilators help to open up the airway and facilitate O2, CO2 exchange. And when we open up those airways, then it makes it easier for us to remove secretions. I have just on this page is a couple of pictures of an endotracheal tube. So you'll see where the balloon is blown up in that endotracheal tube. And so we have to, as I said, be concerned about tracheal necrosis and damage, which is why they can't leave these in more than a couple of weeks. Okay, so you want to assess for circulation, and what I'm talking about is decreased venous return to the heart, because remember, if they're on PEEP increases that interthoracic pressure, which decreases venous return to the heart, which is going to cause them to have signs and symptoms of decreased cardiac output. And if I have decreased cardiac output, then what I'm going to notice is I'm going to notice my blood pressure dropping also. With disability, I mean trauma to that lung. So the higher the PEEP, the more pressure and the more volume, the greater chance for a pneumothorax. So we need to listen to those patients' lungs very carefully, because if there is a pneumothorax, you are not going to hear breath sounds where that pneumothorax is. These are different kinds of medications that the patient may get. These are just for your information. I'm not going to test you on these different medications, but these are medications that we use for sedation when they are on a ventilator. Okay. All right, so ventilator alarms are something else that you do need to know about. The ventilator is always trying to push air in. That's the goal of the ventilator. So you need to assess and treat the high pressure alarm before you silence it. So you need to find out what's causing it first. The most common cause is secretions or a mucus plug. And so what's going to happen is that the ventilator is used to having some pressure, because your lungs have elasticity. They're able to expand and contract. So the ventilator is used to having some pressure to push that air in. But when it has to push too hard, it's going to set off that high pressure alarm. So you need to try to figure out what's going on with this high pressure alarm. So as I said, most of the time there's a lot of secretions. Sometimes what's happening is the patient could be laying on the tubing, or when you turn the patient, you will notice that the high pressure alarm does go off. And so that happens frequently. Mucus plugs are very difficult sometimes to remove. If you are trying to suction the patient and it continues to go off that high pressure alarm, then you need to call respiratory therapy and have them try to problem solve the high pressure alarm. If you can't problem solve and you're noticing that the patient's oxygen levels are dropping when these alarms go off, you just need to disconnect the patient, the tubing from the endotracheal tube or the trach, and you need to bag this patient. So what you have to do is just find out why. Is this patient not sedated very much and they're very anxious? You need to listen to breath sounds to see maybe there's a pneumothorax. And so with a pneumothorax, you're going to get tracheal deviation away from the affected side, and that's going to cause the high pressure alarm to go off. Maybe there's atelectasis going on, and so you just have to try to problem solve the alarm. So make sure, as I said, the big key is if you can't problem solve it and it keeps going off, we need to maintain patient oxygenation. So you will disconnect them from the ventilator and or disconnect them from the trach, and you would need to bag the patient. So all these patients need to have ambu bags at the bedside. The low pressure alarm is what's happening here. As I said, remember the ventilator is used to having some resistance as it's trying to push that air in. So now the ventilator is trying to put air in, but it's not meeting any resistance, and the machine is programmed for some resistance. So low pressure alarm usually means that they're disconnected. That's what I've seen most commonly, is is something's disconnected or there's leaks in the tubing. So what happens is respiratory therapy, they're assigned these ventilators and they will come and check these patients, and that tubing is usually changed every 24 hours. So if there's leaks in the tubing, and again, you can't correct that, you need to then bag the patient. If they're disconnected from the vent and the tubing hasn't been on the floor or anything, then what you need to do is just reconnect that tubing. So low pressure alarms are usually because there's a leak somewhere in the tubing, or the tubing's become disconnected from the endotracheal tube or the trach. The apnea monitor is another alarm that can go off. So you really want to look at your patient, because when the apnea alarm goes off, what that means is the patient's not breathing or the respiratory rate is low. So you really want to look at your patient to see if they're breathing or not breathing. Sometimes this happens too because they do get disconnected from the ventilator. So you do need to think about that. So check your patient to see if they're breathing, and also make sure that everything's connected correctly. And sometimes you just have to say to your patient, breathe. Again, if this alarm is going off and you're not able to problem solve it, then what you need to do is you need to bag this patient, and you need to contact respiratory therapy and have respiratory therapy problem solve that vent. The other thing that you have to do is you have to monitor for complications. And one of the main complications that we see is ventilator-associated pneumonia. And this is very high in patients requiring mechanical ventilation because the endotracheal tube or the tracheostomy tube bypasses the normal upper airway defenses. The other thing is that this patient is immobile. They usually are in a poor nutritional state, and it depends also on the underlying disease process. Many times the underlying disease process makes the patient more prone to infection, such as sepsis. So this can occur 48 hours or longer after this patient has been intubated. So basically what you have to do is think about, what are we going to do for this patient to help prevent ventilator-associated pneumonia? And the organisms that usually cause this are very prevalent in the hospital environment, and they're also prevalent in the GI tract. And so the patient can get this in a number of ways, such as respiratory equipment that's contaminated. Maybe we didn't wash our hands really good. Maybe the patient has a lot of secretions, things like that. So what you're going to look for in this patient is you're going to look at their labs and see what their white blood cell count is doing. You're also going to look at their chest x-ray to see what this chest x-ray is showing. Is this starting to show infiltrates on that chest x-ray? The other thing that you're going to look at is, does the patient have a fever? Okay. Is their sputum purulent in color versus clear? Are you starting to hear some crackles or wheezing in their lung sounds? So those are just some of the things that you're going to start looking at to help determine if this patient is being prone to ventilator-associated pneumonia. Sometimes what we do is they give them a little bit of a sedation vacation, so to speak, and decrease their sedation a little bit and try these spontaneous breathing trials to try to get them off of the ventilator sooner. We do things like elevating the head of the bed, as I already talked about. The other thing is we want to do oral care every 4 hours. The oral care is usually done with a swab with something called Peridex, Peridex, and that helps to keep the oral cavity clean, because you can get organisms from the oral cavity that end up going down into the lungs and lead to infection. Extubate as quickly as possible, and I just mentioned that. As I said, they try to minimize sedation and try to do these spontaneous breathing trials to try to get the patient off the ventilator a lot sooner. Turning and positioning and hydration, those all help to mobilize secretions so we can get those secretions out of that lung. bronchodilators, and very good hand washing. The cuff on that endotracheal tube, what it does is it holds fluids above that cuff and secretions pool. And so that's what we need to be careful about, which is why sometimes you also have to do some oral suctioning on these patients. We do GI prophylaxis to prevent things such as a GI bleed, because remember, these patients are prone to stress ulcers. And so bacteria can grow in the stomach, and these patients can get what we call microaspirations, especially if you have a little minor cuff leak with your endotracheal tube. That can allow some of the bacteria from the GI tract to go into the lung. So pulmonary hygiene is extremely important, which is that turning and positioning and hydration and those bronchodilators. So we really need to do strict hand washing before and after suctioning. You need to make sure you wash your hands before you touch any of the ventilator equipment, those kinds of things. So that's something that we need to think about, is monitoring for these complications. Atelectasis, again, you need to listen to their breath sounds and listen for diminished breath sounds, which can indicate atelectasis. Basically, what we do is we watch their oxygen level. And again, if they're struggling to breathe, we can increase the PEEP and we can increase the FiO2 on the ventilator. So we monitor the blood gases and the oxygen saturation. We've already talked about suctioning, PEEP, and turning and positioning on these patients. Barotrauma, we already mentioned. What happens is we need to be very careful, because we need to watch for this pneumothorax. And that pneumothorax is caused by that increased pressure or increased volume in that lung. And so we have to then be very cautious and assess for that pneumothorax. So you need to really listen to those breath sounds. And on the side where that pneumothorax is, those breath sounds are going to be very diminished, or you're not going to hear them. The other thing that you'll notice is that when you look at blood gases, the patient's oxygenation status is dropping. So we also need to look at that. So how do we prevent this? Well, the goal is to try not to use high levels of PEEP. So we don't want to have that PEEP at 15 or 18 if we can help it, because again, the higher the PEEP, the more we're expanding those alveoli and the greater chance we have for that baro or volume trauma. Also, that's why we're starting to use lower tidal volumes now instead of larger tidal volumes. We used to always have tidal volumes at 700-800, and so now they're a lot lower than that. And we have to be very careful with your COPD patients or your other chronic lung patients, because they're at greater risk for barotrauma, because what happens in these patients is that the increased airway pressure is going to distend the lungs and possibly rupture the very fragile alveoli that the COPD patients have. Or these COPD patients get these little, what we call blebs, and those can also rupture that lead to barotrauma. The ARDS patient, their lungs are very stiff and hard, and so if we increase the pressure in those patients, we also have a greater chance of causing barotrauma. So those are some things that we want to do to help prevent barotrauma and volume trauma in these patients. Other complications you need to monitor for, and we already talked about, is oxygen toxicity. O2 is considered a drug, and too much oxygen can actually lead to oxygen toxicity. So as I mentioned earlier, mechanically vented patients that have high levels of FiO2 for prolonged periods of time are at risk for oxygen toxicity. So, for example, if their FiO2 is 40% for greater than 24 hours, now I need to be concerned about this patient getting oxygen toxicity. So basically our target FiO2 levels we want to try to maintain the SpO2 greater than 90% and our PaO2 between 60 and 90. That's textbook picture. You may see that different actually in the clinical setting. So one of the things we need to do is monitor those arterial blood gases. What are they doing? Are we seeing dyspnea? So what do is we have to try to decrease that FiO2, and we also have to be very aggressive with pulmonary hygiene on these patients. So we also have to think about failure to wean. So one of the other things that we do want to do is we want to get the patient off this ventilator. So when we try to get this patient off the ventilator using the SIMV mode, maybe pressure support mode, or doing CPAP trials, you want to assess your patient. So one of the things we do is what is their respiratory rate. If their respiratory rate when we try to take them off the vent is greater than 30, or their heart rate or blood pressure goes up, this patient is struggling to breathe and they're not ready to come off the ventilator. The other thing is if we are doing this and their oxygen levels drop, then that is another indication they're not ready to wean yet. However, what we always need to think about when we put them on a ventilator is we need to get them off the ventilator. So we always want to keep in mind things that we can do to get these patients off the ventilator. So nutrition is important because your respiratory system has muscles, and muscles need nutrition to maintain strength. So we have to always think about adequate nutrition in these people, which is why they usually have the oral gastric tube, and that is how we give them nutrition when they have an endotracheal tube. When the endotracheal tube is removed and they put in a trach, then they put in a PEG and we give them nutrition via the PEG tube. So how do you know if your patient is ready? Well, your patient is alert and oriented. They talk to you. They obey commands. They can breathe on their own. The blood gases look good. And their hemoglobin level is high enough to be able to carry that O2 molecule around the body. So basically, they have to be able to breathe spontaneously. Now, weaning usually only begins after the underlying disease process that is causing the respiratory failure has been corrected or stabilized. So if it's acute respiratory failure, or if COPD led to acute respiratory failure, then we can think about, once that disease process has been stabilized or corrected, we can begin weaning them. So what will happen is we can use T-piece or a CPAP for weaning. I already mentioned the CPAP on the ventilator and how we do that. The patient is still connected to the ventilator, but we just put it on CPAP mode. And we do those spontaneous breathing trials that I mentioned. In T-piece weaning, the ventilator is removed for brief periods during which oxygen is delivered through a T-piece. And so what happens is they connect tubing to the trach, and then that tubing is connected to oxygen on the wall, and it is humidified oxygen. And so basically what you want to do is you want to monitor these patients' vital signs and their oxygenation level when we do this. If any signs of respiratory distress develop, then the patient is put back on the ventilator. The other thing we do is we look at some breathing parameters. One of them is vital capacity. When we look at vital capacity, basically that's the amount of air that you can take in, right, with each breath. And it's usually 1.5 times the tidal volume. So they can actually measure vital capacity on these patients. The other thing that they do is something called negative inspiratory force, or NIF. And that picture that's on the slide is actually the little piece of equipment that they use to measure NIF. And it's the negative inspiratory force. And what we do is we tell the patient to take a deep breath and hold it as long as you can. And then we look at this little piece of equipment. And if it's greater than a negative 25, then you're able to extubate. So what this is looking at is NIF is measuring those respiratory muscles. So if that number is greater than 25 centimeters of water, then that patient has adequate muscle strength and we can take them off the ventilator. This is that closed tracheal system. This is actually the Ballard suction. If you notice at the bottom left, it says thumb control for suction. And there's that tubing there that you can see in that catheter sheath, and then the catheter is inside there. That catheter is what we put down into the respiratory system, into the trachea, to remove secretions. And so you want to make sure that that comes all the way back out, like I said, because otherwise it can kind of block the tubing and make the area for ventilation a little bit smaller. You also see near the top it says irrigation part for salvage, irrigation port for saline lavage. We don't do that anymore. We don't put fluid down those tubes anymore. On the bottom right where the purple is, that is where you hook them up to actually hook them up to a ventilator. So you can hook them up right there. So you guys have seen this in SimLab. I just wanted to show you a picture though, so you can see what this looks like. Post-extubation, basically what you want to do is just monitor their breathing. Many times we can extubate a patient or take out that tube and the patient starts having some respiratory problems, and then we have to re-intubate them. So what you need to think about is if there's any stridor. Stridor is life-threatening, okay? Stridor is heard on inspiration. So this is something that you need to look for. You also need to look for intercostal retractions. When they're struggling to breathe, you can see their chest just sink in. So these people are really struggling, and we need to do something to support their respiratory system. What you can do as a nurse post-extubation is give them that incentive spirometer. Every time you walk in that room, you just need to say, here, show me how good you're doing on this. Make sure they understand how to use it. Because when you use an incentive spirometer, the first thing you need to tell that patient is to blow all their air out, put the mouthpiece in their mouth, inhale slowly. When they can't inhale any higher, you need to tell them to hold it for a second, remove the mouthpiece, and let the air out. So incentive spirometers should be given on any patient that's in a hospital. We need to cough and deep breathe them. We need to keep the head of the bed elevated. We need to turn and position these patients. We need to get them ambulating. If they can get up and move, get them up in the chair. Do anything you can do to keep these patients moving. Okay, so some key points. Always assess the patient first, regardless of what that ventilator is saying. Okay, what is that patient doing? You always want to keep emergency equipment at hand. You always have to have that ambu bag there, all right? If patients have a trach in, you always end up having a second trach available at the bedside, because sometimes people can cough out those trachs. You always want to keep the patient comfortable, and you do need to remember that ventilators are only supportive and they're not curative.